CDK4 and 6 inhibition is considered to be a milestone in the realm of targeted breast cancer therapy. The combination of CDK4/6 inhibitors with the endocrine therapy has really emerged as the foremost therapeutic modality for patients diagnosed with hormone receptor positive, HER2 negative advanced breast cancer.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS, and today we're talking with Teresa Knoop, Independent Nurse Consultant in Nashville, Tennessee, about CDK inhibitor drug class. This episode is part of a series about anticancer drug classes, which we'll include a link to in our episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome. Thanks so much for joining us today, Teresa.
Well, thank you, Jaime. I appreciate the request to be able to participate in another podcast, and I welcome all of our listeners.
Wonderful. Let's start with a brief overview of the history of CDK inhibitors in the field of oncology.
Well, absolutely. As we all know, dysregulated cellular proliferation is a hallmark feature across all cancers that we deal with. And molecularly targeted therapies have been developed to address those areas of dysregulation. Monoclonal targeted therapies have been used in cancer treatment now for over 25 years, which is a bit mind-boggling to me. And they can be either chemically or biologically made. For example, rituximab was the first biologically made monoclonal antibody, FDA approved in 1997, and imatinib was the first chemically made small molecule kinase inhibitor, FDA approved in 2001. Now, small molecules target dysregulated malignant processes within the tumor cell in what is known as the intracellular environment. And these small molecules have a variety of intracellular targets, and they are given non-proprietary names, or we sometimes refer to them as generic names, that are dependent on their class. For example, one class of small molecules is known as CDK4/6 inhibitors, and that class of agents targets specific proteins known as cyclin-dependent kinases 4 and 6. Abbreviated as CDK4/6. Aberrant activation of the cyclin-dependent kinases 4 and 6 pathway leads to uncontrolled breast cancer cell proliferation. So CDK4 and 6 inhibition is considered to be a milestone in the realm of targeted breast cancer therapy. The combination of CDK4/6 inhibitors with the endocrine therapy has really emerged as the foremost therapeutic modality for patients diagnosed with hormone receptor positive, HER2 negative advanced breast cancer. And this therapeutic approach has demonstrated a substantial extension of progression-free survival, also known as PFS, often amounting to several months, when these drugs are administered alongside endocrine therapy. Some of these drugs have now shown efficacy as monotherapy or combined with endocrine therapy in the adjuvant hormone receptor positive HER2 negative breast cancer setting. Currently, there are 3 FDA-approved CDK4/6 inhibitors in commercial use. Palbociclib, trade name Ibrance, was initially approved in 2015. Ribociclib, trade name Kisqali, was initially approved in 2017, And abemaciclib, trade name Verzenio, was also initially approved in 2017. So these drugs have been around for a few years now. As you listen to this podcast, you will note that all of the currently FDA-approved CDK inhibitors have non-proprietary names ending in CICLIB, cyclib. You can also be assured that any CDK4/6 inhibitors in clinical trials or those that will be newly FDA approved in the future will have names ending with the stem of cyclib. This allows us to be able to easily recognize this class of agent.
Wonderful. Thank you so much for that very comprehensive overview. Let's talk a little bit more about the mechanism of action that is associated with the CDK inhibitors.
Absolutely. As our listeners know, if a breast cancer is hormone receptor positive, it means that the cancer's growth is fueled by the hormones estrogen, progesterone, or both. In hormone receptor positive breast cancer, activation of the estrogen receptor signaling pathway upregulates the CDK4/6 pathway. And the cyclin CDK pathway, we know, plays a pivotal role in cell cycle regulation by driving the transition of cells from the G1 stage to the S phase. So we have to kind of go back and think about the different phases of the cell cycle. In more basic terms, if we're breaking that down, what happens? Well, when you upregulate those CDK4/6 proteins, that, by the way, are found both in healthy cells and breast cancer cells. They control how quickly cells grow and divide. In a very basic way, that is what they do. And if they're aberrant, those cells tend to grow and divide faster. In breast cancer, it means those proteins become overactive. And then the cells, the breast cancer cells, tend to grow and tend to divide uncontrollably. CDK4/6 inhibitors, by blocking an enzyme, interrupt those proteins in order to slow down or even stop the cancer cells from growing. And additionally, we know that HER2-negative breast cancers do not respond to HER2 targeting agents. And we also know that advanced stage breast cancer could be either locally advanced or metastatic. Therefore, when you inhibit both the CDK4/6 pathway and the estrogen receptor pathway, that combination of blockade has shown clinical efficacy in hormone receptor positive, HER2 negative, locally and advanced metastatic breast cancer. And this affects a large number of patients, as more than 2 out of every 3 breast cancers fit the description of being both hormone receptor positive and HER2 negative. All of the current CDK4/6 inhibitors are approved with endocrine agents to treat advanced stage and metastatic hormone receptor positive, HER2 negative breast cancer. There are actually 2 of the CDK inhibitors, ribociclib and abemaciclib, that are FDA approved to be combined with endocrine agents adjuvantly after surgery to treat early stage hormone receptor positive, HER2 negative breast cancer with a high risk of recurrence. So they were initially approved in the metastatic setting. Then 2 of these have now moved to the adjuvant setting. And then one of these drugs, abemaciclib, has an additional indication to be used as monotherapy after a hormone receptor positive, HER2 negative breast cancer has progressed following endocrine therapy and chemotherapy. That's a lot to take in a podcast. What I want you to glean from that is the common thread is that these CDK inhibitor drugs are currently used in several different ways in the hormone receptor positive, HER2 negative breast cancer populations only at this point.
Thank you for all of that information. You're right. It is a lot. You can just tell in the way that you described it, what a momentous, pivotal class of drugs to be approved for that subset of patients who have that type of breast cancer, as you described. What an important advancement in the treatment of that disease. So we've mentioned them a little bit, but let's revisit some of the examples of these agents. And are there any other subclasses of CDK inhibitors, or are they all generally in the same class at this point?
At this point, the CDK4/6 inhibitors are all considered to be in the same class of drug. And again, we're right now just looking at 3 drugs that have reached FDA approval. The first one, as I said, was approved in 2015. The last 2, FDA approved in 2017. But the thing we need to keep in mind is there are ongoing clinical trials of these new CDK4/6 inhibitors, as well as trials exploring new ways to utilize the drugs that are already on the market. For example, I mentioned they started in the metastatic setting, and 2 of them have now moved to the adjuvant setting. So trials will inform us as to new agents and new ways to use those.
So let's talk now then a little bit about the common toxicities that we see, also called adverse events, that are associated with the CDK inhibitor class. Can you talk a little bit more about that?
Sure. Common toxicity among this class of agents are things like nausea, vomiting, diarrhea, fatigue. All 3 are associated with low white blood cell counts, which we know is neutropenia, which can cause an increased risk of infection. And across the board, there's also a potential for interstitial lung disease with these drugs. Now, remember that this pathway promotes the cell cycle, and you can find this pathway in both cancer cells and healthy cells. So you're probably hearkening back to, okay, these are kind of some common toxicities we often see with chemotherapy. So just keep that in mind, that these kind of work across the board. And then there are some really particular adverse events that we see in each of these drugs individually. For example, abemaciclib is known for causing sometimes severe diarrhea. They all can cause diarrhea, but it is kind of notorious for potentially causing severe diarrhea and possibly hepatotoxicity. And ribociclib can cause QT prolongation, severe cutaneous adverse reactions, and hepatotoxicity. So not only do they have some commonalities in toxicities and adverse events, but they also have some very particular adverse events you need to be aware of.
Thank you. I think those are all, as you mentioned, just very important to be sure you know what is unique about the class across the board, but also recognize that individual agents may have their own nuance. So it is important to be aware of that. And so thank you for walking us through that. What are some of the pharmacology related strategies that should be used routinely to prevent or to manage those toxicities?
2 come to mind right away. Certainly for the nausea and vomiting, antiemetic meds may be needed across the board in those drugs, but particularly with abemaciclib, antidiarrheal medications like loperamide may be needed to manage the diarrhea that could often become severe with that drug. So those are the 2 main pharmacology strategies that we use with those toxicities.
We know that this is an oral drug. So are there any administration considerations that nurses should keep in mind when administering these drugs, the CDK inhibitors, to their patients?
So as we know, these are small molecules. We talked about that in the beginning, and small molecules typically are in the form of pills because they have to cross that cellular barrier to get intracellular to work on their target. All 3 of these CDK4/6 inhibitors are pills taken by mouth, and in most cases, they're all given along with endocrine therapy treatments. So patients will be taking more than one drug. Teach patients how they will take their medication. And the frequency among the 3 drugs may vary. So if you're switching from one to the other, please keep that in mind. For example, abemaciclib is taken daily and it continuously, either with an endocrine treatment or alone. It does have one indication for monotherapy, while palbociclib and ribociclib are taken with endocrine therapies 3 weeks on and 1 week off. So patients have to be really cognizant that they're taking those therapies those 3 weeks, and then they are getting a break on that 4th week. Patients and caregivers need to know the time of day to take the pills, whether they need to be taken with or without food, or what to do if they miss a dose. And we need to help them with a system for organizing the medications. They may find it helpful to use a pill organizer or set reminders on their smartphone, their smartwatch, their computer. There's so many ways to help us keep up with when to take our meds so that they can stay on track with those medication schedules.
Absolutely. And let's continue with that. Obviously, educating our patients, their caregivers, their family is a really important point, especially when we're dealing with these oral drugs that patients are administering to themselves at home. So, what are the primary patient education points that you recommend we communicate to our patients and caregivers when they're taking CDK inhibitors?
Yes, well, there are actually several that come to mind to me when we're talking about this class of drug. And the first two are just how they're getting their prescriptions filled and the cost of those drugs. The CDK4/6 inhibitors are generally ordered and mailed to a patient's home through what is called a specialty pharmacy. And this is as opposed to a local drugstore or a pharmacy where patients are more accustomed to going to get their medicines. And they typically will be mailed out to the patient's home. And this may be unfamiliar for the patient and the caregiver. So there will be a lot of coordination needed and communication between the physician's office, the pharmacy, and the patient. Secondly, we need to assist patients in investigating prior to being diagnosed these meds what their out-of-pocket costs will be, because even with insurance, the costs can be high. Depending on the patient's income, they may qualify for financial assistance from the manufacturer. And as oncology nurses, we can guide them in this process. Of course, we never forget about teaching our patients about adverse events and drug interactions. They need to know about all of those adverse events we talk about, both the common events, here's what you're very likely to see, or the rare events, and also how to manage those adverse events and when to notify a healthcare professional. That is probably one of adherence, and when to notify about side effects are very important when these patients are home taking these oral medications. ONS actually has a great checklist that teaches nurses appropriate baseline assessments and ongoing monitoring to do for each of these drugs in this class, as well as an excellent chart that includes dosing, adverse reactions, and patient considerations. Great tools to help us as oncology nurses know how to teach our patients. Now, the other thing to keep in mind is all of these drugs have potential drug-drug and drug-food interactions. So that is very common with small molecules, that they will have drug-drug or drug-food interactions. So we need to explore whether those patients are taking any other medicines or food that might interact with the CDK inhibitor. We need to, in these cases, be particularly aware of concurrent CYP3A inducers or inhibitors and grapefruit or grapefruit juice with each of these drugs. Those things should be avoided, and we have to, it's incumbent upon us as nurses to make sure we have asked those questions. Also, you want to ask about any complementary or alternative medications or agents they may be using. We need to be careful with ribociclib about drugs that cause QT prolongation. And once again, teach our patients to alert their healthcare professional anytime they add any additional medicine, whether it's prescribed by a different doctor or over the counter. We have to know that because we have to ensure there are no interactions. And that's important because if they're taking these drugs, we do not want a second drug that could interact to either make the drugs they're taking less efficacious or to make them have worse side effects. So it's really important to check those interactions. Also, these patients need to know that they should be prepared for dose adjustments, especially during those initial weeks of treatment. They really can expect to have frequent blood tests and liver function tests as they start on a CDK inhibitor. And based on those results and any symptoms they are having, such as severe diarrhea, fatigue, low white blood cell count, it may be necessary to lower the dose or have the patient take breaks from treatment. Patients need to know this is fairly common and not a cause for alarm, that you will help them through this. Adjustments often have to be made to help them get the benefit of the treatment while they minimize the side effects. ONS also has a published adverse reaction dosing guide for these drugs, and these guidelines for adjusting dosages can be found on the website of each one of these drugs. With abemaciclib, plan in advance for preventing and managing diarrhea. About 80% of patients taking abemaciclib experience some level of diarrhea, and you certainly don't want that to get too severe. And this especially is prevalent during the first months of treatment. And often patients are maybe a little hesitant to tell you they want to stay on the meds. So we need to let them know we can help you through the management of these side effects. And there is also a chance, if those white blood cells are low, if they are neutropenic, that they could develop infections. And the risk is certainly increased. With palbociclib and ribociclib, these counts tend to be lowest during the third week of their treatment cycle. Remember, they do 3 weeks of treatment, take the fourth week off, and usually around the third, they have the lowest counts. The basics of teaching people about decreasing risk of infection apply here: washing hands, using hand sanitizer, avoiding large crowds, and staying away from people who are sick.
Well, as you've just described, clearly there is a lot to educate our patients and their caregivers about, from risk for any of those adverse events or side effects, assessing if there's any drug interactions, monitoring for needed dose reductions, lots of work to be done. And so thankfully, many of us are able to partner with clinical pharmacists in our practice environments. So how do you recommend that pharmacists and oncology nurses collaborate and kind of share the load of managing adverse events and toxicities, providing that necessary patient education, and also just serving as that trusted source of information?
At my institution, I worked in a large academic medical center, and there was a very robust collaboration network between our pharmacists and our nurses. We need to make sure that we are all involved with these patients so that when we collaborate and work with them, we want them to be able to understand how to manage those side effects. There are also things like we need to make sure together that they know how to get the initial prescription and refills. As I said, it may be through a specialty pharmacy. There's a lot of collaboration on the front end between pharmacy and nursing to get those prescriptions started and get those mailed to the patient, as well as helping those patients maintain those refills. These drugs, as we mentioned earlier, can be expensive, and patients need to know their insurance coverage and the out-of-pocket costs. So often we as nurses and our wonderful pharmacists collaborate with each other. We also, I want to point out, collaborate with financial navigators to help us determine that patient cost and hopefully find those patients who need financial assistance, some assistance that may be available through the pharmaceutical company. Additionally, pharmacy and nursing, in my experience, collaborate greatly on determining those drug-drug and drug-food interactions. It's so crucial in determining those interactions and educating our patients, because we have to remind patients at each appointment and review these drugs and foods and other things they may be taking at each appointment. And that often can be done by either pharmacists or nurses or both in collaboration.
What do you think the future looks like for these agents and their role in the landscape of cancer care?
Well, it's pretty exciting to think about, because you keep in mind that these approvals are likely to evolve over time as clinical trials are still ongoing to figure out if CDK inhibitors can benefit additional groups. Considering the effectiveness of these CDK inhibitors in hormone receptor positive, HER2 negative, locally advanced metastatic breast cancer, as well as in the adjuvant setting, these drugs are now under investigation in various breast cancer subtypes and different clinical scenarios, such as CDK4/6 inhibition in neoadjuvant therapy. So the thought is, okay, they can help in a certain way in metastatic disease or locally advanced. And then we look at, can they help in the adjuvant setting, which they have shown they can. Now you look, okay, let's look at the neoadjuvant setting. And all of that is to make sure we're offering every patient we can offer this potential therapy so that we have something to offer every population of patient. There are also several preclinical studies that have indicated CDK4/6 inhibitors may boost tumor cell immunogenicity, and that may lead to the exploration of these drugs together with immunotherapy agents like immune checkpoint inhibitor combinations. Preclinical and early clinical investigations have also indicated that CDK inhibitors may augment the response to HER2 targeted therapy. These, as we know, we use in HER2 negative populations now. But all of these combinations are so early, preclinical, very early, and they have to be studied further for efficacy. So I have to make sure that overlapping toxicities are tolerable for our patients. So a lot of work to be done, but I think that we will continue to find novel uses for these CDK inhibitors.
That's really exciting to hear. It sounds like this drug class is not going anywhere and, in fact, will be used probably in different timings, different settings, and in combination with different therapies as studies continue and we see the results of what those studies show. It sounds like this is going to be a timely podcast topic for years to come for us to revisit all of the wonderful foundational information that you provided us today on our podcast. So thank you so much, Teresa, for that. As we reach the end of our podcast, we do always like to run through some quick fire questions just to help summarize some of the main topics that we've discussed. And so to start that section off, how do you think healthcare professionals can evaluate their hidden or their implicit bias when it comes to CDK inhibitors?
Now, that's a really interesting question because it is something that every day we all need to address. And palbociclib, ribociclib, and abemaciclib have not been directly compared to each other in a clinical trial, but they're generally considered to work equally well in FDA-approved populations. So decisions of what drug to use may depend on a lot of factors, such as stage of breast cancer, prior treatments, if any, whether the patient is pre or postmenopausal, the adverse events associated with each inhibitor, the preference of a patient taking medicine continuously or on a 3-week on, 1-week off cycle. And finally, we have to consider whether the patient's health insurance favors one of the medications over the others. So lots of factors. And I think the lack of really any comparative data can lead to potential bias. I did discover a 2019 article by authors Matani and Vogel, and it indicated that despite the gains in efficacy, some physicians are still reluctant to use CDK inhibitors in combination with aromatase inhibitors as first-line treatment in postmenopausal women with hormone receptor positive, HER2 negative advanced breast cancer because of concerns about efficacy, safety, and cost. So some of the same factors we just discussed. The author's review of the data indicates, though, that CDK inhibitors improve performance status in all eligible patients. And while they do tend to have more adverse events when they are combined with aromatase inhibitors compared to just aromatase inhibitors alone, the patient-reported quality of life is comparable, and those adverse events seem to be generally manageable with recommended monitoring, as we've discussed. Patient costs do remain a barrier with all three of these CDK inhibitors on the market, but keep in mind that patient support programs may greatly reduce those costs for some patients. An assessment of this barrier, rather than use our bias and say, oh, we definitely can't give that patient this drug, we need to look at it on a case-by-case basis alongside our desired efficacy and safety concerns. And if we feel like the cost may be prohibitive, we need to explore not stop there, but explore potential financial assistance or other ways for the patients to get those drugs.
Absolutely. Wonderful. Thank you for all of that information. What are some common misconceptions about CDK inhibitors?
While CDK4/6 inhibitors are a specific class of treatment agent, and we expect our patients to have similar side effects, we do need to keep in mind that those individual drugs, there are 3 of those, they may have specific different side effects. And I think we've talked about this, but I just want to reemphasize about abemaciclib being more likely to cause more severe diarrhea, ribociclib with the QT prolongation and severe cutaneous adverse events. So, yes, the drugs in this class have some commonalities and side effects, but be very careful to look into each specific drug that is prescribed to make sure that we teach the patients about the potential side effects that may be specific to a particular drug.
What's something about this topic that's not often discussed, but you wish people knew more about?
I do want nurses, as I've said, this class of drug is generally well tolerated. And I do want nurses to know that we can help patients with these side effects, and they are generally well tolerated with appropriate management. But keep in mind, there can be more severe adverse events that need to be identified early and monitored closely. For example, while interstitial lung disease is rare, it can be encountered in any of these 3 currently approved drugs. So a thorough pulmonary system baseline must be established to be able to identify and treat any initial indications of interstitial lung disease. Interstitial lung disease could be potentially life-threatening if treatment is delayed. So we never want to forget that these kinase inhibitors, much like many of our other targeted agents, can result in interstitial lung disease. And we want to have a baseline, identify that early, and be able to do the early steps to prevent any progression of interstitial lung disease.
Absolutely. I think those rare but serious side effects are sometimes not as easy to recall or as fresh in your mind. But as you noted, certainly very important to be mindful of and to not dismiss those early symptoms when they present themselves.
Yes.
What additional training or education do oncology nurses need to stay current on this topic?
Well, once again, I'm going back to ONS because ONS has a learning library on breast cancer. And in the learning library, and if you haven't discovered these learning libraries of ONS on the ONS website, please do so. They are so incredibly helpful. The Breast Cancer Learning Library has an entire section specific to CDK4/6 inhibitors. There are articles, videos, a plethora of resources. I've told you about some of those as we've gone through the podcast, where you can learn more about these drugs. So I really suggest starting there. It's a great starting point.
And then finally, are there any additional resources for maybe patients or other providers who would want to learn more?
Yes, I would recommend breastcancer.org. It seems to be an excellent site for healthcare practitioners, particularly for patients and caregivers. The Komen organization has a great section on CDK4/6 inhibitors. And finally, lead the patients to the drug website for the drug they are on. These websites always have a health professional section and a patient-specific section. So for both of us, going to those, that's where we find out what's the data behind this. If we're a health professional, what are all of those adverse events? What's the data that got this drug FDA approved? For a patient, it's very specific recommendations of how to take care of themselves while they're on these drugs.
Well, Teresa, as I said before, thank you so much for all of the wonderful information and your time sharing that with us and our listeners today. I always walk away learning so much from you, whether it's a presentation at Congress or one of these wonderful podcast episodes. You always bring so much information to share. So I greatly appreciate your time. Do you have any final comments to share with our listeners today?
I want to thank you, Jamie. I want to thank any of you who are listening in today to take the time to do so. And I appreciate those comments from you. To really summarize, I would just say nurses need to know that these CDK4/6 inhibitors combined with endocrine therapies or in monotherapy have really revolutionized the management of hormone receptor positive, HER2 negative breast cancer. These very novel therapies emphasize the importance of us continuing to discover personalized treatment strategies for the many subtypes of breast cancer. There is not just one type of breast cancer. There's so many that we have to address, and continuing to study these drugs is going to benefit an increasing population of our patients. So thank you for listening, and thank you for all you do to help our patients manage to be on these agents.
Thank you so much, Teresa.
You're welcome.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.